Hello, I'm Paul Louis Metzger, the Director of the Institute for Cultural Engagement, New Wine, New Wineskins. Welcome to New Wine Tastings. It's my privilege to introduce to you Dr. Robert Potter, who is a friend, a longstanding friend, I'd say, over the last several years. Dr. Potter has served as an advisor to New Wine, New Wineskins and Multnomah Seminary, pertaining to an American Association for the Advancement of Science grant, and also is working with us in a conference we have coming up this very week on disabilities, from isolation to invitation, a conference on disabilities. And so Dr. Potter has a degree in medicine. He's an internist. In his background, has worked a lot with palliative care and geriatrics. And then also he has a doctorate from the University of Chicago in the realm of psychology, ethics, and religion. Robert, thanks so much for joining us at New Wine Tastings.
I am so pleased to be here.
Robert, tell us about your interest. You're one of the conference organizers for us with New Wine for this conference this week about disabilities. Tell us why this conference matters to you.
I can remember back when I was a kid being uncomfortable about people who were in wheelchairs and walked with walkers and had crutches and weren't normal people. You know, they were the disabled people, and I did not have a particularly good understanding of what was going on with the disabled person. I remember in college, in Lawrence, Kansas, where I went to Kansas University, there was a man with no legs who had had amputations clear to the groin. And he would sit in his stumps on a little roller, like a skateboard, and roll up and down the main street in Lawrence, Kansas. And I remember being stunned when I would see him. What is going on in the life of this man? And you know, then as I became a physician and started doing internal medicine, what was I up against? I was up against the older person who's had a stroke, who's had an injury, his arthritis has crippled him up completely, who's had to have an amputation because of diabetes and no circulation to a limb, or multiple other disorders, both physical and mental, that make people as they age become less and less able to be, as we used to say, normal. And I began to understand that there was only one appropriate attitude for me as a professional or as a human being generally to have toward the disabled. I need to approach them with a profound sense of humility. I remember it very distinctly when a man aged 36 who had had his neck fractured at age 17, driving while drunk, now quadriplegic, in a wheelchair, married, drives to work every day. Michael said to me, you know, Potter, those of us who are disabled know things about life that you will never figure out. And I think that is so true. I see them, Paul, I see them as spiritual giants. You know, have been through the worst that could happen to a human being, and here they are, functional.
Yeah, the resilience is amazing.
The resilience is amazing. What allowed them to do that? Yeah. How can they do that? I am so fascinated. When I was teaching at the University of Kansas as professor there, I'd get students, I say, students, approach this with humility, and do not ever say to a disabled person, oh, I know how you feel. Because you don't know how they feel. You don't know what they're going through. You haven't lived their life. Don't ever say that. What you need to say to a disabled person is, what can you tell me that I need to know so that I can better care for you? That's the question. What do you want me to know about you? Yeah.
So an inquisitive, humble posture that's inviting them to teach us on how to care, how to engage, how to support. You've served in a variety of hospital settings. You've already mentioned University of Kansas Medical School, and you've also served at OHSU Oregon Health and Science University in medical ethics.
Yes.
Over your career, what are some of the pressing challenges you have encountered in seeking to serve the disability community?
Well, I think the disability community has their particular important and unique issues when it comes to ethics in healthcare. The chief item that we try to, the principle that we try to teach in medical ethics is, to the extent possible, the patient should be the decider of what happens next. You know, we go to the patient to ask them, here are the options, what do you want done? The disabled person may not be fully able to receive information or to express an opinion. And there's where we have to be very patient, sometimes use more interpretive methods to get somebody to communicate adequately with us. Sometimes it's a speech pathologist I need to have in the room to tell me, okay, what is this person trying to say to me? Their words are not coming out in the usual English language. You know, they've had an injury to their speech center and they can't tell me what it is, but they're thinking nonetheless, and they have the capacity to make the decision. Help me understand what their gestures, what their partial words are, so that I can understand what they truly want. So it's patience in dealing with disabled people so that their disability does not block their being able to make decisions of their own. I guess the next to that, Paul, is this. There are some folks whose disability is such that they are not able to make good decisions for themselves. And that determining, as we say, determining decisional capacity was one of the most difficult things I ever tried to do as a physician. To try to decide whether this person in front of me is functioning adequately, that they are giving me an informed decision about what they want done, or whether their mental processes are just simply at a level that they cannot do that for me. To say you are not decisionally capable means that somebody else is going to make decisions for you about you. And that's a very, very difficult position for me to be in. But I have to do it. Sometimes the best thing to do is get some consultation. Sometimes a psychiatrist can help us with understanding a person's mental status. Sometimes it's a cognitive psychologist that can help with some various testings. But it's always a difficult thing to do. So those are the two things. First of all, being very patient to work with the person. By the way, when I say the word patient and person together, I just have to stop a little bit and be my pedantic old professorial self, okay? The word patient in English is derived from the Latin verb root patio, which means to suffer. A patient is a person who suffers. And for me, disability still is a suffering, even when people's resilience has allowed them to rise above it and they act as if they are not suffering. It is still, for me, I have a sense that they are suffering at some degree. So, being patient with those patients and helping them make decisions, and then that difficult crisis point when I have to decide that they are not able to make. Those are the first two things in ethics that I think about, okay? There are lots of other situations and specific little cases that we could talk about, but those are the two big ones that I have to constantly be aware of and that I use in my practice and in my teaching of others.
And it's also grounded in your personalist philosophy, so to speak, of the person before you, as you said earlier, being the one who is predominant in terms of the decision-making process. And that's where humility comes into play as well.
Agreed. The humility that they are going to know better than you know.
Yeah. Thank you. So much of your work is focused on geriatrics and palliative care. What are some of the unique dynamics of providing medical care for elderly people and people at the end of their lives who have disabilities?
Well, I'm one of those odd docs that made house calls. And when you walk into a person's house and discover that they're walking with a walker, and there are 3 steps up the front steps that you could barely make as an able-bodied person, you realize there's an arrangement problem here. There's a structural problem here. When you walk into a person's home who is disabled in some way, and why don't I take stroke as one of those common kind of disabilities that I would deal with, so I don't have to keep qualifying that over. Walk in somebody with a stroke. What am I looking for? I'm looking all around to see what is this habitation like for someone who's disabled. Are there throw rugs over there that they're going to trip and fall on? In their bathroom, are there rails for them to grasp as they get up and down off the stool? Are there places where they can sit down readily, say where you would ordinarily be doing dishes? Is there a place to sit close by where if they tire they can just slip into it? You look for all kinds of ways in the structure. Then the second thing you look at is who else is there with them? Is there another person who's caring? Is that person working through the day and then coming home and getting exhausted and maybe getting... Sometimes, care partners sometimes get a little angry. They just get worn out and they get angry, and you have to look for that. A lot of resentment in people who are trapped in caring for their mother or their husband or their grandma or whoever it is that is in the household. So it's looking to see who's around, and you check out with them who else in your family or among your neighbors or among your friends who are available to you for transportation, for going to the grocery store, it's trying to find out what is the social web in which they exist. It's not only what's going on in their head that's important, but also what's going on in their social relationships that's going to allow them to live their best in this situation, in this place. So those are the things that I look for. And I can't do that over the phone.
Right.
I can't do that in the office. I need to go to the home.
Yeah, excellent, excellent. I think this is going to lead right into the next matter before us, and that is a great deal of attention goes to helping those with disabilities physically or biologically. Some recent literature has criticized such preoccupation for not accounting sufficiently for sociological and psychological factors. And I think you were engaging both the biological and the sociological just a minute ago. You wear 2 hats. One is a medical doctor, and also one is a medical ethicist, social psychologist. How have you tried to account for both dimensions? And you've mentioned a stroke victim, the biological and the sociological or psychological in your practice. And you just mentioned one, I think, but would there be another where you've tried to do that? I think it comes naturally to you, but you're wearing 2 hats all the time, I think.
Sure. But I think that one of the traps that physicians generally get into is to see themselves only as body mechanics.
Body mechanics.
You're a body mechanic, I know how your heart pumps, and when it's not pumping, I know what the problems are. We're going to get your pumper going better. So, that's just body mechanics. And you can learn that. It doesn't take... I used to say, the practice of medicine is simple. It's the patients that make it difficult. the physiology and all that. It's just a bunch of stuff to memorize.
It's almost as if you've had me as a patient.
Yeah, because when I say it's the person or the patient that makes it difficult, it's the person's attitude, their willingness to participate, their capacity to overcome the insults of life. Those are where the real problems exist. And I used to think that the more I would know about psychology and sociology, the more I would be able to help repair that part of what happens in a human being. I'm less confident in that than I used to be. I think there's something about that healing that arises out of a combination of that individual's relationships with the network of people that within which he is held in his existence, and how that network of relationships is understood to be the way in which God the Eternal is loving and caring for that person. Those are things that I can talk about, maybe teach a little bit, but they're the things that the individual themselves are going to have to actualize, to realize, to engage in. And I sometimes believe that what I can do as a physician is to invite the person in to that relationship. Say, there it is. Take advantage of it. Participate in it. See that the loving relationships in which you exist are the way that God is loving you in every way. And I don't know whether that's more scientifically justifiable than the way of, the usual standard counseling but I found that when I was dealing with people who needed really to overcome their spiritual disability, that was the thing, it was the one I was really the most afraid of, was the disability of the spirit. When they're caught at that level, I can't fix that. That's fixed with an encounter with the Holy Spirit. And the best I can do is invite them into understanding that their relationships are the relationships through which God the Almighty is touching them every day. Mm-hmm. And letting them grow within that. Yeah, I think it's a far more honest way to approach that level of working with the disability, because the disability is obviously more than the body. It is more than the psychological. It's up into the spiritual realm where we truly exist. So that's my answer to it. And it may sound just a little bit like I've given up on my psychological science, but it's not. Psychological science has revealed much of that to me. That psychological science has limits as to what it can do. And I think that the limits, when you're at the edge of the limits, that's when the spiritual power, the spiritual energy begins to come into the equation.
So there's the physical, there's the psychological, there's the social or sociological, there's the spiritual. And yeah. I think going back to your house calls, you were seeing people as more than just in a cubicle or in an office, correct, in a medical building with you. You were trying to see them in their ecosystem, their relational ecosystem, and that has to be accounted for. And that's why we're doing this conference, from isolation to invitation, and ultimately inclusion. Yeah. The solutions are going to be found within a communal context, not in isolation.
I'm absolutely convinced of that. Absolutely convinced of it.
But just a few more thoughts. Some of the critics of the biological approach to addressing disabilities talk about a predominant emphasis on trying to quote-unquote fix people, as you mentioned, the kind of biological mechanics, so to speak. A sociological model seeks to account for social factors such as prejudice toward those with disabilities, a lack of sensitivity, and insufficient access and accommodations. Certainly these are important matters. Please share how your particular approach to ethics, which you've already alluded to, seeks to take each situation on its own terms and accounting for the person before you, rather than having a cookie-cutter approach where one size fits all.
Yeah. Well, I think I'll revert to just a little schema which I have used to guide my own life and to teach others. And that there are three primary questions about every life situation. If I come into a life situation where I'm asked to help deal with a person who is disabled with a stroke, let's say again, keeping to my example, my first question is, what's going on here? The second question is, what ought I to care about? And third, what's the fitting response that allows me to care? Mm-hmm. The first one, what is going on here, requires not only the physiological diagnosis, the neurological diagnosis of how much brain damage has occurred here, what are they stuck with, what part might recur, or might be rehabilitated yet, or maybe they've been through a year of rehabilitation and they are left with a residual. To be realistic about what's going on here is a starting point always in anything, whether it's ethics or other decision making. What is really going on here? And so often I find myself asking the question, does this person coming to me as disabled, do they understand all they need to understand about the reality of their situation? Let's say there's a person who has been in rehab for 6 months and they've made a little bit of progress. They're able to walk now with a cane. Maybe their speech was mildly impaired to begin with and they're beginning to talk, making a little more sense, and they're very pleased about that. And they say, oh, I'm going to be well one day. I'm going to be able to do X, Y, Z without any sense of the stroke. I have to confront that with the reality that their recovery can be yet more, but not yet is it going to be complete. Mm-hmm. That they will have to be looking at the future. So every now and then I have to challenge the person to be realistic about what is their life situation.
Yeah, what is going on right now.
What's going on right now. Now, out of what's going on right now, there are a lot of different things to care about. As a physician, I need to sort out all the things that I ought to care about and find that core piece that I need to focus on right now. That's what's necessary to do. Out of all the things that are to care about, maybe I'll come back to another one someday, but right now, this is the one we're going to care about. And I'll give you an example. What I care about in you, Paul, since you had your stroke 6 months ago, I noticed that you're not going to rehab like you did. You know, you were very faithful, going every week for a while. Now, you know, they say they rarely see you. Paul, do you understand that if you're going to get better, if you're going to reach your maximum of recovery, you have to go to rehab every week. So you notice what I'm doing here. I'm saying, here's your life situation, here's what we ought to care about right now. Okay. And I have to feed that back to the person, saying, this is what I care about, this is what you ought to care about, and let's decide to do that. What's the problem? And I find out that his transportation is so unreliable that he can't get there without begging somebody. We're going to work that out. Right. So I can contribute to that.
Right, you know? And that's part of that. What's going on here?
That's right.
Well, so it kind of feeds back.
Yeah, so right. Yeah, these 3 steps are not 1, 2, 3, and then forget about it. They're 1, 2, 3, 1, 2, 3, yeah. 1, 2.
So what's going on here? What do I need to care about?
What's the fitting response to what's going on here? So yeah, and those 3, constantly keeping that in mind, keeps me focused on what I can do for the person before me here. By asking the question, what's going on? What ought I to care about? And once we figure out what I ought to care about, is there something I can do? Now, sometimes in medicine, there isn't anything more I can do to fix your stroke. But maybe it's time then to move to a different level of care. You know, how are you going to live the rest of your life with a weakness in your arm and leg? How are you going to give thanks for your existence day by day? Crippled. You're crippled. How are you going to deal with that for the rest of your life? Now, I'm not going to ask you that way.
He's really asking me some tough questions here.
I'm being a little tough on you now. I'm sort of playing the role of professor here.
Yeah,
you know,
yeah. It's good. It's good.
But I think that facing the big issues of disability can be overwhelming. And what I've decided to do mostly in my practice is cut the big picture into small pictures and decide I'm going to care about this right now. And then pretty soon I'll be caring about something else in the situation. But gradually you put the picture together and you get the maximum out of it as you possibly can. But I just want to re-emphasize once more, Paul, that if I'm not listening to the one who's suffering, if I'm not listening to the patient, I'm not going to know what to do, because I don't know what's going on inside them. I can pretend like I do, but it's the delusion. I've got to hear it, I've got to process it, and we're willing to call that ability and willingness to hear and process, we'll call that empathy. But to say that empathy means that I can know what you're going through is just simply not part of my vocabulary anymore. Because when it comes to disability, the only one who knows what they're going through is the one who's going through it.
Thank you, Robert. I just love the emphasis on humility and on a holistic orientation involving biology, psychology, sociology, and spirituality. So needed. I'm looking forward to hearing you share about this at this conference this week, From Isolation to Invitation, a conference on disabilities. I'm Paul Louis Metzger, Director of New Wine, New Wineskins, with my good friend, Dr. Robert Potter. Thank you for joining us at New Wine Tastings.